Welcome to West Midlands Evidence-Based Emergency Medicine, applying rigorous data and research for optimal patient outcomes.
Hello and welcome to this review from West Midlands Evidence-Based Emergency Medicine. Today, we're getting stuck into a paper that really gets to the heart of a common worry for all of us in A&E. What really happens to a patient's blood pressure when we give them IV furosemide for acute heart failure? Right, let's picture the scene. We've all been there. It's 3 a.m., you've got a patient in front of you who is, to be blunt, drowning in their own lungs. You know you need to give them furosemide, but then that little voice in the back of your head starts up, doesn't it? Hold on, what if their blood pressure bottoms out? And this leads us to what we're calling the furosemide fear factor. It's this very real shared anxiety that often makes us hesitate. We're so worried about causing hypotension that it can actually dictate our entire management plan, sometimes meaning we don't give enough of the drug that the patient desperately needs. Now, this isn't just something we've made up. The authors of the very paper we're looking at today, Harrison and colleagues, call this out right at the start. They state that this fear can lead clinicians to either hold back on a life-saving therapy or just give doses that are too low to really make a difference. So with this being such a common clinical sticking point, a group of researchers decided it was high time we actually put this fear to the test. They set out to do something that, believe it or not, hadn't been done before, to properly measure the precise effect of IV furosemide on blood pressure right there in the A&E setting. And let me tell you, this was a proper study. They looked at 253 patients across several different emergency departments. Now, the crucial bit is how they monitored them. They used continuous, non-invasive finger cuff monitoring. This is a huge deal because it gave them a real-time, second-by-second picture of what was happening, leading to an enormous data set of over 91,000 blood pressure readings. So after collecting all of that incredibly detailed data, what did they actually find? Well, the results are honestly pretty surprising, and I think for most of us, really quite reassuring. Okay, so here's the big question they wanted to answer. When you think of all the things that make a patient's BP go up and down in A&E, their starting BP, other drugs you're giving, their general condition, what slice of that pie is actually directly caused by the furosemide? And the answer, just 1.4%. Yeah, you heard that right. After they adjusted for everything else, the amount of BP variation that could be pinned directly on the furosemide was tiny. This chart just puts that into perspective perfectly. See that tiny little sliver there? That's the furosemide. All the rest of it, the other 98.6% of why a patient's blood pressure changes, is down to everything else. You know, their baseline blood pressure, other medications, and just how sick they are to begin with. So what this all boils down to is that the direct impact of furosemide isn't some huge, dramatic BP crashing event that we might have built up in our heads. The effect they found was actually quite modest. It was predictable based on the dose and the patient's starting BP, and it was transient. It wore off within 6 hours. And this table really shows us what that means in the real world. It shows the total time, in minutes, a patient might spend with a systolic below 90 in the 6 hours after getting a dose. So let's take a patient with a starting systolic of 120. Even if you give them a decent 80 mg dose, on average, they'd spend just 7 minutes hypotensive over a 6-hour period. I mean, that's remarkably low, isn't it? Okay, so if furosemide isn't the main culprit for causing hypotension in these patients, then what is? Well, the study gives us some really clear answers on that front too. It really came down to 3 main things. First up, and by far the biggest predictor, was the patient's starting blood pressure. Simple as that. Second, certain patient factors played a role, like having a very low ejection fraction or being of an advanced age. And third, and this is super important for our practice, was the other drugs we give at the same time. This slide really hammers that last point home. Look at this. On its own, 80 milligrams of furosemide was linked to about a 12 millimeters mercury drop in systolic pressure. Okay, but now look what happens when you start adding other common treatments into the mix. Add in some NIPV, and that effect more than doubles to a drop of nearly 25 millimeters mercury. And in the rare case a patient got IV diltiazem, well, the drop was a staggering 47 millimeters mercury. It's these other interventions that are the real game changers. So let's boil all this down. What does this actually mean for you on your next shift? How can we take this evidence and apply it to the patient sitting in front of us? Let's get to the clinical bottom line. First things first, we should feel pretty confident about these results. This is, after all, the first study to ever properly measure this specific risk. The way they designed it, prospectively with that continuous monitoring, gives us incredibly high-quality data that you just can't get from checking a BP cuff every 15 minutes. But of course, like with any study, we've got to be aware of the limitations. It was observational, not a randomized trial. And really importantly, these results don't apply to our absolute sickest patients. We're talking those in cardiogenic shock or with really advanced end-stage heart failure. The patients here were your more typical, uncomplicated heart failure admissions. So here are 4 key take-home points for your practice. 1. Be reassured. The direct effect of furosemide on its own is pretty modest. 2. Check the baseline BP. If their systolic is over 110, the risk of significant hypotension is really very low. 3. Mind the mix. Be most careful when you're combining it with other drugs that drop blood pressure, especially vasodilators. And 4. Maybe it's time to reevaluate underdosing. Based on this evidence, fear alone probably shouldn't be the reason we're not giving a proper, guideline-recommended dose. Ultimately, what this paper does is it empowers us to reframe our clinical question. For the vast majority of patients we see with acute pulmonary edema, the immediate threat to their life is hypoxia because their lungs are full of fluid. It's not a small, temporary drop in blood pressure. So maybe, just maybe, the question we should be asking ourselves isn't, can their BP take the furosemide? But rather, can their lungs survive without it?